or a case or something you'd like to discuss? Does anybody have something on their mind already?
Actually, I do. I've had a recent inquiry from one of my patients about the non-pharmaceutical management of attention deficit disorder.
Excellent.
And specifically focusing on foods, and I think the one subject area that focuses, I suppose, is to have more fish in your diet to achieve some benefit, if any. And I want to know what your opinion is. Is there benefit? If so, what's the data behind it? And can we be concrete in our recommendations to patients?
Well, those are wonderful questions, and I was expecting you to ask me about cognitive training too while you were at it. If I missed that, we can certainly bring that one up as well.
No, I like the non-pharmaceutical. That's a really great question. I get that a lot too, so I'm anxious to have a discussion about that.
Fantastic. So Bob, maybe you can start off by telling us, you've been in both sides of the country, and California is often the first place to come up with non-pharmaceutical and maybe a lot of pharmaceutical interventions for various things.
San Francisco is one in particular. That's where Running with Ritalin started by Larry Diller.
He wrote the book, yeah.
Wrote the book and had some pushback.
Negative things to say about standard treatment.
Yeah.
Right.
So that's sort of a hotbed. Did you hear that question in the West Coast or the East Coast?
Or both?
I'm sorry, are you asking me a question?
Yeah, I'm asking you if you heard that, if you heard about it more in San Francisco or Cambridge or both.
I think probably more in the Cambridge area, only because, not necessarily because I've done work here, because I have not at this time. We just moved probably 6 months ago, so there's still some time for me to get my feet wet again. And this question, after 30 some odd years of pediatrics, has become real because we have people asking us and wondering, is there a benefit or not? And I think, as far as West Coast is concerned, there's certainly regional differences in our West Coast. When I look at San Francisco, the city itself is fairly conventional, and we typically use pharmaceutical management as a significant part of our practice in managing the attention deficit disorder. But I think if you go a little bit north into Marin, the opposite holds true. There's almost a denial effect where they think that there's no reason why they should subject their child to these poisons. I have to take a deep breath when I deal with those patients, and frankly, it's important to us, I think, that we have a basis in fact. If we can address the issue and we can say, okay, these are things that you can consider without feeling like you're doing something terrible to your child. And I think that most of us want to be conventional in our management and find something that works and works well. But perhaps we should consider, if maybe not change, but consider our particular position on that area.
Well,
so there's regional difference.
Right. First of all, I admire your attitude about it, because one of the most important things for us to do as clinicians is never to just put somebody down because they have a different idea. And so I appreciate the carefulness with which you're considering this, because often this is a fairly long conversation, because we're talking about medicating a child perhaps indefinitely, because only a third of kids grow out of their symptoms of ADHD, right? So medicine can be helpful for most people for their whole life. And so thinking that you're going to give a kid medicine starting maybe as early as age 4 and going on and on and on and on and on, that's a pretty big commitment. And so we as physicians, I think, because we've got 80 years experience with stimulant medication and its safety, I think we get kind of relaxed about its safety. But other people, when they're thinking about the future for their kid, they're not feeling so relaxed. And so they are very interested in what some alternatives are. So I think I wanted to start off with some of those comments. And
I'm glad you brought up, it's not just omega-3 supplements. There are many alternatives that this is a cultural issue. And first of all, whatever, we can talk about the evidence, and there is some evidence for omega-3s that may be useful. There was evidence for omitting red dye, and when you really looked at that evidence, there were a subgroup of kids who had some improvement, and in both those cases, the improvements are small, and the evidence is scanty compared to stimulants. But the larger question, and I'll tell you, give you an opinion that an approach I take, and you'll see that Emily has a difference from me on this one. But I'll tell you, over the years, there are a number of other alternatives that come up, and people wonder about our culture, essentially the bigger picture, and what are we doing with what's our objection to stimulants, and I'll tell you the point of view that I've taken. I see you can say, there may be something, maybe omega-3s have some benefit, but what if they said some other vitamins, that there are all kinds of other alternatives? And I think I've seen that one impulse is to say, that's just not scientific, and I only do evidence, and so you'll have to go someplace else. And Barbara was suggesting that we are part of the art and caring for these kids is to understand the perspective of the parents and be open to it. And so I'm going to tell you how I deal with that and have over a long time. What I say first is that, there are many other ideas about it, and that I'm open to things that, first of all, if they're harmful, I will tell them. If they're not harmful, I'm open to considering them. And this is how I consider things. First, my cultural perspective is I ask them about the use of the most common stimulant that's used in worldwide, and it's not Ritalin. The most common stimulant that's used is caffeine. And when we take that perspective and understand that the caffeine and the stimulants that we use for ADHD are very similar chemicals and have similar effects, and that the major difference is in our cultural perspective, the cultural perspective being that 90% of adults worldwide are consuming caffeine. In this country, averages 3 cups of coffee, caffeinated coffee per day, plus some caffeinated sodas. And the reason that people take that stimulant is to be more alert and productive in the workplace. So I think that's something I try to put on the table. And also note that caffeine has many more side effects than this, as far as we know, than the stimulants. That there's withdrawal effects, and then the parents always say, "Yeah, have you know about that? You can get a headache or bellyache or something like that if you suddenly." That doesn't happen with the stimulants used for ADHD. So I get into the perspective of use of stimulants per se, and I do believe there is a contradiction in our culture about no controversy about caffeine, but big controversy about these stimulants for kids, and of course going over the safety and how many years and studies, and knowing that this is effective, and that it has to be something that works in the moment of this classroom. So having said all that, then what I always do for new patients, I always offer a stimulant placebo dose finding trial. So all patients, because we want to have objective information. So once you set up and you discuss having a trial, and so what we're going to do is we want to be sure that the bias, people have biases. Some teachers may think that stimulants are an anathema, and or others, it's the best thing since sliced bread. We want to be sure that we're getting unbiased opinion, so we do a double-blind controlled trial. I do it for 6 weeks, double-blind. The parents don't know, and the teacher doesn't know, and the doctor knows. Okay, not double. Maybe it's called single. It's 1.5 blind. So I do it for 6 weeks. It's always placebo, low dose, high dose, placebo, low dose, high dose. I do it for 6 weeks. At the end of every week, there is they do the ratings. We do it in a way that presents a graphical picture of teacher and parent ratings, and then we display it. So I'm engaging them, and then coming to Omega. I say, now, if there's anything else, if you want to put omegas into the picture, well, let's have a week of omegas, and then they may come up with something else a year later. Say, that's fine, but you know that my standards are, it should be something that's not harmful and something that is we can prove to be effective in your child. So let's try omega-3s, and if that works better, let's use it. And so we get into a contract that looks like objectivity, avoiding things that are known to be harmful, and being open to an objective outcome. So that's my take on it. Now, going back to omega-3s, as far as I know, there have been a number of trials, and some of them have shown some effectiveness. It's not strong an effect as with stimulants, and the data is on the iffy side, but it's not a crazy thing to try, and I would do it in that context because we want to be sure it's effective, so let me just say this about the trials. And I've been doing this for many years, and what you find is that I get the emergency calls. I'm not kidding you. That my kid this is terrible. He's drugged out. He's zoned out. Or he's hyper or whatever it is. And I can't stand it any longer. The child is on placebo. And the worries that the parent have usually come up on placebo. And I say, you think you can hang in there for one more day? He's been on placebo for 10 years. I don't say that. But when we review it and we say, which one, I say, certainly don't want the green one. And that's the placebo. So that's the way we're working through the culture. That's a long answer. I'm sorry, but that's my perspective on that one and the other alternatives.
So let me just say, this is Barbara Howard. Let me just say a little bit more about omega-3s. So you've probably heard of a medicine, it's considered a medicine, it's called Viarin. And Viarin is omega-3s, and it was approved for treatment for ADHD. But the trouble is that these trials are usually not very long, and there's a very large placebo effect. But it is omega-3s, but it's a very expensive way to get your omega-3s. So if a patient is going to use omega-3s, they might as well just buy omega-3s and make sure they get enough of a dose. It's extremely difficult to eat enough fish to get the same amount of omega-3 as was shown in the Viarin medication trial. So
nothing wrong with taking Viarin.
No, there's nothing wrong with it except it's expensive. So if they're interested in trying it, omega-3s are actually good for all of us. We should probably eat more of them, as long as you make sure that you don't get one that has got, mercury in it because it's made from fish, and they would check the contents of that. So I do not discourage people from using omega-3s for that reason, but those are some of the caveats that go with it. By the way, omega-3s do have a little bit of evidence for helping with depression too. And so, and since depression goes along with ADHD, that's another reason to think about it. But I agree with Ray's point of view about setting the stage and telling people, we're going to help you be as scientific about it as you can. And just as we do with autism, we don't want people to spend years with ineffective treatments figuring out if they work, because during that time, the child is suffering in many ways that might have been helped by medication. And in particular, that, for example, pediatric intensive care unit admissions and head injuries and car crashes are all much more common in kids with ADHD. Of course, some of those are younger kids who are running into traffic, and then there are older kids who are driving cars and so forth. So it's not a benign disease. It's not a benign condition, actually, in terms of your overall physical health. It's not benign to have ADHD. So I'd love to hear, Bob, your comments back, and also Emily, where you are with this.
I just want to add that the people concerned about this are also maybe concerned about mercury in the fish, and that when you're having a concentrated amount, you do have to be sure it's mercury free. As I said, we want something that's safe. Not right. That's safe. That's safe. Okay.
Emily, do you want to comment? I'm sure you deal with this question about whether there's something else.
I would say that I will just say up front that the patients that I see as a child psychiatrist are often, not always, but often different than the patients that primary care folks will see. Mm-hmm. So that's either just partly because you all take care of the vast majority of kids with ADHD. So the kids that make their way to a child psychiatrist often have either more severe or less straightforward to treat ADHD or comorbid ADHD with other problems. So sometimes those families have already been trying some of these alternative strategies. I think I find the guidelines in Up to Date very helpful, and they have 5 bullet points that I think Ray touched on and I think are worth thinking about. So the first is just to review the stated goals or in treatment, then review the evidence and benefits and potential adverse effects, to encourage families who want to try alternative therapies to try them one at a time, and to define and monitor target goals and core symptoms to see if it's working, to encourage families to determine a time frame in which they expect behavior changes to occur as a result, and then encourage families to use evidence-based behavioral interventions and or medications at the same time that they're trying CAM therapies or alternative therapies, so as not to Barbara's point, so as not to perpetuate suffering on the patient's part. I think there are also times when families are doing things that could be harmful, like megavitamins and things like that, which can do damage that families don't realize. And then we could redirect them to perhaps still less evidence-based, but known safer things, whether that's yoga, mindfulness, or other kinds of things that do not have adverse side effects the same way, is another piece of the pie. My general stance is that if I don't think it's going to harm a patient, I'm fine if a family wants to do that, as long as they either are willing to do the things that I know the literature tells me will work in addition, or if we've agreed to, okay, we're going to try X, how long are we going to try it for, and how are we going to tell if X is working? And so we've set an agreed upon set of parameters that we're looking for, and what the timeline is for when we're going to decide if it's working or not. That, I would say, though, is the exact same thing that I do with any pharmacological prescription that I would write, which is, what do we think is going to change? How long, what is the time window in which we think that thing is going to change? And at what point are we going to decide that's not enough change or that is enough change to continue?
Right.
Thank you, guys.
Needless to say, this kind of, working through this kind of concern requires fairly frequent contact with the patient. And one of the things that's noted to be one of the biggest reasons primary care pediatricians don't do as well as mental health professionals is that they don't see patients often enough and make enough changes in dose to optimize treatment. And actually, in the MTA study, multi-site, multimodal treatment assessment, I think it was called, for ADHD, I forget. What they found was that when using exactly the same stimulant medicine, community physicians did much worse than mental health professionals, mostly because they didn't optimize dose. So just
based on teacher feedback.
and the inclusion of teacher feedback. So that's a good thing to keep in mind. So Bob, I'll give you a chance to see if we're addressing some of the things you were thinking about.
Sure. Let me focus back on two things. First, omega-3 therapy, and then try to integrate that with the use of pharmacologic management, specifically looking at methylphenidate, since it's probably the most common of our pharmaceutical treatment regimens. So, to go back to the beginning, when I have been fumbling my way through the treatment, I started with the pharmacologic management using methylphenidate is our first drug, generally speaking. And I would do it based on a weight-based regimen, 0.3 per kilo for starting dose, maxing out at about 1 milligram per kilo is our upper end dose. So that was my format. So when I was listening to the description of the double-blind trials, for me, you would have to go through each one of those dosing regimens to reach the maximal benefit with minimal side effects. But also the second thing is, if we do that, let's say we have a patient we've been caring for, they're at 1 milligram per kilo for the methylphenidate, and we're getting some improvement, but this is not a total cure. And they're going to say, okay, his writing improved, he seems to be paying more attention in class, but his social skills still suck. He basically he's a problem child at times, not just in school, but also at home. So anyhow, the second thing I wanted to say is that if we have done that and we haven't maximized benefit, perhaps then we should consider something like omega-3 added to that regimen. And what's the pharmacologic management dosing? How do you do the 0.3 per kilo and the 1 per kilo of Ritalin? How do you do that with omega-3? What's the dosing recommended?
Okay, so those are good questions.
Let me address some of those. The first one was about how do you get the right dose. That's really important. And we had this per kilo idea, and I believe that there's more weight on the side of individual differences. The people are saying maybe you should check their genetics and enzymes and so forth. But in fact, younger kids may need a higher dose than older kids, and it's based on teacher ratings if the issue is in school, and so it's optimizing medication based on outcome. And my outcome mostly.
There is no need to send genetic testing. I don't want anybody to get the wrong idea. Yeah,
I agree with you completely. I'm recommending. No, I'm not recommending that at all. Okay. What I'm saying is that what we want to do is to see how optimize functioning and minimizing some side effects. But getting back to the first question about dose, what I do in this trial is I take a low dose and then I take a relatively high dose for that child. And that helps me to speed up the process of getting, because you can go, you get a little effect and you go for years at a suboptimal dose for a child. And I believe I take 6 weeks, but that we're going to get to that optimal dose sooner in that way. And the right dose of omega-3, I don't know, except is one that I have used when parents are interested, and we do. I get feedback. I have my experience is that there's some enthusiastic ones, but once they go through the stimulant trial, they stop using this alpha, the omega-3s. So that's my perspective. But I think that even when the parents don't come up with an alternative beginning. I think in our culture, you have to realize that at some point, all parents, and my assumption is all parents are going to be swallowed up on some cyberspace at some point, and be intrigued by alternatives. And somebody in the family is going to. That's why I set it out in the very beginning that we're going to have a systematic trial with anything that you come up with, and because the biggest challenge is not so much that they're going to they may not even start using medication, but when you look at the long-term data, for some reason, a year later, years down the road, and one of them is that the kid's a teenager and he doesn't want to use it anymore because it's not cool. Something like that's going to happen. And our real challenge is for long-term treatment of not just an acute benefit.
But let me just say something about the dosing, Bob. So one of the things that's important to know is that children who are primarily inattentive presentation, do better on lower doses, and children who are predominantly hyperactive, impulsive, do better on higher doses. And it's not very weight specific. So I just want to say that you should be bold enough to actually try to optimize for the individual kid until you either see side effects that are not okay, but don't be so tied in to the weight, because that's really not how this medicine particularly works.
Yeah.
There's general guidance, but it shouldn't stop you. And then the second question you asked is, if it's not working at your optimized dose, you didn't say this, you said, if it's not working at the dose you've chosen, should you add something else? And so let me go back and say, if it's not working at the dose that it's optimized to, yes, it's fine to add something else. Keep in mind, omega-3s take a long time to show any effect, so that would be going on for a while. But there's other adjuncts that can be very helpful added on to stimulants. And those adjuncts are usually alpha agonists like Intuniv, or something like Strattera, which has a completely different mode of action. Now, Strattera takes a very long time to start to work. They say at least like 9 weeks. So that's why you get a lot of advertising for it over the summer, because they say, well, let's start it up over the summer. That's atomoxetine, because it takes so long before you get to a beneficial effect. So keep in mind that there's other things besides omegas that can be added on, particularly if you're getting a child who's very irritable or has side effects on a higher dose, does okay on a lower dose. Sometimes adding one of those other ones can be very helpful.
Or switching from class, that is methylphenidate versus the amphetamine groups. There are some that respond to one versus the other, and we thought that big MTA trial years ago was going to settle that, but it never did. So it's empiric. So my first reaction, if we really are optimizing the dose, would be to take the other class of stimulant. That's where the evidence is strongest. Yep. and before these supplementary kinds of medications and non-pharmacological treatments certainly are very important.
Right, and I want to talk about cognitive training in a minute, but let's see. Anybody have any other comments or questions about this area?
Or other case that they may want to talk about?
Yeah.
I have one comment. This is Natalie. I'm a family nurse practitioner. I have a pediatric mental health certification too, so I deal with a lot of ADHD patients and parents. A lot of times parents, I think, struggle when their kids become behavioral issues. You know, they put that label on them either in school or socially. I've really been a really big proponent of encouraging the parents themselves to participate in either parent training or they themselves get some CBT to help decrease the stress of taking care of a hyperactive child at home. I've had several parents tell me that they themselves have to medicate themselves because they, quote, can't deal with their child's behavior. So at that point, I really try to encourage the individual, so not only the parent, but also, you know, the family to help the dynamics there. It can be very hard to, I think, discipline an impulsive child if maybe the parent has some similar characteristics themselves. So in addition to some of the other things that have been discussed, that's one of the things that I really promote in my practice for my families and patients who have a diagnosis of ADHD.
We totally agree with you, first of all, and remembering that 25% of kids have a parent with ADHD, 25% of kids with ADHD have a parent with ADHD, and sometimes helping them get management for their ADHD is in fact very important. But there's particularly some evidence for mindfulness training also, besides parent training. Like, mindfulness can help you stay cool when you need to. And if you're not familiar with it, mindfulness is basically allowing thoughts to go through your mind without judging them, without acting on them, and often accompanied by relaxation or deep breathing exercises. And it's easy to learn how to do this through online apps or classes, and that can really help parents cope with kids with ADHD. Mark Burton has written a good book on that and has evidence for it. So that's something to keep in mind as an additional thing that would help. But just knowing how to manage behavior well is really very, very important. Helping parents to locate such resources is sometimes difficult. So I'm glad that sounds like, Natalie, you are such a resource. But often people come up short on looking for such resources. But parenting classes sometimes are held in schools, and there's some good books too that can be helpful. 1, 2, 3 Magic, even that, which has videos as well. A good resource if people don't have anything else where they can go and get some help with it.
Yeah, I've been I listened in on the last month's phone conference too, and I really have been incorporating and providing even just a couple of minutes to my visit with really promoting mindfulness more. And I've looked into some classes locally for myself so that I can, really promote that a little bit more in my visits. And I'm also hopefully going to do some sort of training for for my office staff too, to really help with that also. So I'm really going to make that a priority moving forward and have to really try to incorporate it.
That's great. That's great. Okay, great. So we got some people coming and going here. Does anybody have a different topic? And I don't want to forget, or a case, right? And Bob, you're welcome to put in another one if you'd like.
Well, you invited me, so I want to say one more thing along the line of the management of ADHD without completely changing it. And that issue is the follow-up and initial diagnosis can be made a lot easier when we have tools that help us along the way. And, oh, by the way, Ray and Barbara, thank you for Janice. It simplified my life a great deal.
Fantastic.
The use of the Vanderbilt scale has been my primary component that I've used in managing the children with ADHD in terms of follow-up, as well as helping me to solidify the diagnosis. Do you have any comments about that, or do you have any suggestions for alternatives if other people have not chosen Vanderbilt?
Sure. So first of all, you're exactly right. And the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry both recommend that you use the standardized tool to assess symptoms, and that you do that as part of the initial diagnosis, but also as part of follow-up. So you're exactly right, Bob. So good. I'm glad you're doing that. The Vanderbilt all of the tools are pretty similar, frankly. One of the differences is the Vanderbilt is free, and that's good because we want you to use it all the times that you need to use it. So alternatives include...
In Janice, we also have the Connors.
We have the Connors in Janice, but that's also available to you, outside of Janice, of course. There is a cost for that one. There are a number of other tools. The SWAN, for example, SWAN. I don't even remember what that stands for. There's also a preschool ADHD tool that's been validated reasonably now too. That's in Janice. It's called, I think, Preschool ADHD Rating Scale. It's good to have a tool that's validated at younger ages because the Vanderbilt doesn't have a lot of data at younger ages. So that's a nice thing to have in your toolkit. And then when you get into teenagers, so the Vanderbilt actually has a change in scoring when you get to 17. So it's it requires fewer symptoms actually to be considered significant after 17, but it doesn't actually say you can use it 18 and older. And I know pediatricians and psychiatrists deal with lots of people after that age. So there is an adult ADHD rating scale as well. So it's good to have a variety of these tools available. Emily, do you have other favorites that you like besides that set?
No, I would agree with you.
What I find the thing about the rating scale I like the best, frankly, and now I'm going to talk about Janice, is that to have a graphical representation. When we can show, I love to show parents that the parents view over time and the teachers view, and green is good. Everybody, they teach that in kindergarten now. Green is good and red is bad. Orange is in between, and that's the way the way it lights up over time. That kind of graph, and there are others outside of Janice who have something like that, but it's being able to share decision making, and along those lines, one of the guidelines for ADHD care is to review for any chronic illness, is to review the goals that the parent has. And that's a useful, what goals are they looking for? And you may be surprised once you start asking that question. And, you've got all these symptoms that you're interested in, but the parent may be, she's just got to show respect, or, whatever they've got be under their bonnet about is important to track also. So there is a tool, the Goals for Change tool that we've published. You don't have to use Janice to use it, but the idea is they pick out what their primary goal is, and I think there are 18 sub-goals. That came from 500 parents who were seeking care for their kid for ADHD. So we try to track their goals, and also in Janice and however else you're doing it, we have handouts that are sort of default related to the issue that they're struggling with. So somehow tracking goals as well as symptoms are the two most important things.
And actually, those are part of the American Academy of Pediatrics recommendations that you should do that. So whatever tool you choose, you want to get familiar with it and be able to use the same tool over and over again, and because that allows for comparison. But let me just tell you a couple of the strengths and weaknesses of the Vanderbilt. So one strength of the Vanderbilt is that in the initial Vanderbilt, it also asks about emotional comorbid conditions, so anxiety, depression, and conduct problems. And that's really, really important. It's not like a highly validated set of questions, and you could very well use other questionnaires that assess those same things, like a depression questionnaire, an anxiety questionnaire, and a conduct questionnaire. You could do that, but it is a good way to get started with that. So that's a good thing about it, but you only get it if you use the initial form. And so one of the things that people sometimes do is they use the initial Vanderbilt for initial evaluation, and then they use the follow-up. They don't have those other things where comorbid conditions often emerge over time. And so I would recommend that you continue to use the initial form. That's the only difference. The other thing that I wanted to mention is that the Vanderbilt doesn't distinguish what time of day the symptoms are worse. Now, it does ask that on the teacher form, when do you see this kid? Like, when is the class that you see this kid? And that can help if the parent and the kid know what time of day that is, because often what happens is the parent, when they do the Vanderbilt or any of these other forms, they're thinking about 7:30 at night when they're having a horrible time getting through homework, getting the kid towards bed, all of those struggles they have when the medicine is actually worn off. And that's not a fair way of assessing the effectiveness of a medication. So it's really important. And we've actually added the time of day that's hardest to the Vanderbilt in order to address that very problem. So I would just make that other caveat about thinking about the emotional comorbid conditions and about the time of day questions.
Yeah, no, I'm glad you brought that up, Barb. I find that's the other thing that's key is when there is a time of day, you're giving them the long-acting medicine. The box says it's supposed to last 12 hours, but some kids it may last only 6 hours. And so it gives out at 1:30, and then you have a differential diagnosis. Is it the math class? Is it the medicine's worn off? Is it where he's sitting in the class? Is it the subject of math? Is it the teacher? So those are really important issues in managing kids with ADHD because anyhow we've added the time of day part after the rest of the Vanderbilt, so it doesn't mess with the psychometrics of the test, but that's a key issue to get the teacher to tell you when it runs out, because the parent really doesn't know it. It's hard. And I always ask the child also, when does it seem to wear off?
And they can often tell you.
Kids
although
can
I have to say that kids with ADHD are kind of like the fish in the water. They're not necessarily very good judges of their own symptoms, but sometimes they can tell when they're struggling more, and they'll be able to report that to you.
Yeah, that's the other thing. But that the self-administered teen ones is that the teens are not very introspective. They're not good at noting their own symptoms, but it does keep them involved. And when they get to be 13, I often do a placebo trial with the child who wants to give up taking medicine at that point, which I think is a developmental achievement to understand that they try to decide, are they a cool guy or are they some kid who needs to take medicine? And it's a little bit of an existential thing I find comes up about age 13. And getting through that and for them to own it themselves is an issue. And self-ratings are helpful at that point.
Okay, did that address a little bit about the instrument question, Bob? Or anyone else?
Yes, it does. Thank you.
Good. Good. So, any other questions or any particular patients you want to talk about? Anybody on the call?
I was on a little bit later, so I apologize if you guys covered this earlier. When it comes to the comorbid condition of anxiety, I've had a couple of recent adolescents who I feel very comfortable that they have both components. And in starting their treatment, what kind of pearls do you have as far as which entity do you address first from a medication standpoint? Are you comfortable starting both an SSRI and stimulant medication at the same time? Do you prefer to kind of pick the problem that seems to be the most prominent and start with that one? My usual sort of comment to parents is that I don't feel like the ADHD medications make your child anxious. They don't cause anxiety to come that's not already there, but it certainly can allow anxiety symptoms that are underlying to be more prominent, because now the child can have a little bit more, I guess, ability to focus on what kind of makes them anxious. So I try to weed that out and try to make sure the parents know that I don't think that there's not really a chance of their stimulant medicine causing their child to have a new novel anxiety diagnosis. But just from a style standpoint, what can you comment on kind of what your approach is in that 13 to 15-year-old who has, strong symptoms of both ADHD and anxiety? How do you kind of tackle that?
Well, those are wonderful questions, and I'm going to give Emily the first shot at this one. I have some opinions, but I'd love to hear Emily's point of view.
Sure. Yeah, I think I would agree with pretty much everything that you said. I think that it is true that the stimulant medications are not going to induce anxiety in a not otherwise anxious kid most of the time. I don't think that's such a big issue. I think it can, as you said, make it harder for anxious kids. They can feel worse on a stimulant. But I try to do as you were suggesting, which is, okay, for this particular kid, which one of the group of symptoms, the anxiety or the ADHD, really is causing distress? And that may be distress for the youngster, distress for the family, distress for a parent, distress for the school. and try to go after that, the most distress first. My general preference, having said that though, is to target the anxiety first, because that is harder to get at and is a much more internal experience for the youngster. And by going after the anxiety first, I'm doing a number of things, I believe. One is that I'm validating the internal experience of that early teen. And I think that confluence of development and identity and self-efficacy and confidence and self-advocacy coming together and trying to have a clinician say, no, we hear that you're saying you don't feel right on the inside. I think that's an important thing to do. I think that we also know that it's going to take a little bit longer for an SSRI to work. So I want to get that going as soon as I can, because I know it's going to take a couple of weeks. The good news about stimulants is that you can know pretty quickly if a kid is either going to tolerate it and or if it's going to help or not. So I find it relatively easy to add that on after we get the SSRI going. But the other thing that impacts my decision-making and the conversation I have is how skittish or supportive a family is about either diagnosis and or intervention. So we all have families who they only see the ADHD and they think we're nuts when we say the kiddo is anxious. And we have it that there's all anxiety. There's nothing wrong with them, with their ability to pay attention at school. It's just that they're really worried. So I think you also have to put it in the context of the family's beliefs and expectations, and use that in a way that supports their engagement rather than turns into a battle of wills. I think, when parents come to see the child psychiatrist, they often have developed great expertise in power struggles. So I want to make sure that I don't bring out that skill set in any way, shape, or form. And so I really want to understand where are they, what are they most comfortable with, and where am I going to get the biggest bang for my buck? I also will talk with families about temperament. And so sometimes it's an anxious temperament kid who has ADHD. Other times it's a kid who doesn't have an anxious temperament but has developed an anxiety disorder of some sort. And so I want to understand how they see their kid and how they see the target relief of symptoms, because that's going to help me aim correctly. I'll stop there.
Oh, those were great comments. Wendell, does that help a bit with it?
Yes, it does. I have a particular case that I'm kind of working on now where it's a 15-year-old elite swimmer who is, I think, quite clearly ADHD inattentive type, and probably quite clearly anxious, has anxiety disorder as well. And initially, I think those are great comments, and I appreciate that. And that's the approach I took initially, in that I started an SSRI, and we hadn't gotten too far into time on the medicine when the child was complaining, the adolescent was complaining that his swimming was affected by taking the medication. He felt like he had his worst times in years, and didn't really attribute that to any special anxious feeling before the meet, but felt like the medicine was making him feel too sluggish and too off his game, and so kind of abruptly stopped it. Dad's a physician as well, and so Dad is, I've had to kind of tell him to stop managing things in the background, because he was trying to apply his input from a medical standpoint and his background of himself seeing a therapist for anxiety, and I was asking him to try to recuse himself a little bit from the process. So I thought he was confusing my picture, and so then I said, okay, well, since you're clearly not interested in having your swimming be affected, and I agree with that. He was starting to have more issues with his grades starting to fall from him being a little bit more inattentive and having trouble focusing in school. That didn't seem to be anxiety based. So I said, okay, well, let's approach this from taking the ADHD now, since the initial treatment of the anxiety was met with resistance from a lot of people's standpoint that he didn't want to continue medicine. And I felt like going to another SSRI at that point in time, which I think clinically is the right move, sort of mentally he wasn't ready for. So I then started stimulant meds to try to address some more issues. The teachers were telling us that he was losing focus and not participating to his fullest, and the teachers had independently expressed concern to the parents. So I've started some ADHD medicine on him, and so things were going okay at first, and now all of a sudden I get a call, she's spiraling downwards, she's having some anxiety moments, and he's in with a counselor that I like very much and trust very much, and we are very much have a collaborative relationship, and so she's going to see him tomorrow. We're going to talk again after that to help me determine next best steps. But the dad's now like, well, should we go back to the SSRI? I want to stop the stimulant medicine, and I'm like, well, let's not change anything just yet. Let's not rush to make all these changes. Keep him on the medicine. Let him talk to his therapist, and the therapist and I will talk the next day to kind of come up with a game plan. But my thought is that I was going to keep him on stimulant medicine, because I don't want to keep going back and forth with that. And I think his underlying symptoms that his teachers were reporting, I'm going to find out if they are in fact improved on the medication, and then I was going to proceed with going ahead and starting him back on another SSRI in hopes that he would be able to tolerate, stay on it, not affect his swimming, and then be able to hopefully see the fruits of his anxiety control in addition to having ongoing therapy.
Well, Wendell, you've pinpointed one of the biggest challenges in dealing with ADHD when you get the mix of ADHD and anxiety. I find that the inattentive kids are more likely to have that kind of mix, and it's very tricky. And often both things are right. What I often end up seeing is that, yes, it's helping him focus, but the problem is he's focusing more on his worries now too, and that is the way I see it. That really happens that way. For the swimmer, you can be sure to remind him about Michael Phelps and his Ritalin. He's a poster boy for stimulant medication and swimming, and sometimes you have to decrease the dose, and there are kids who it does take time to get the right mix, and it could be that even the same SSRI might help with some stimulant on board. It's not a this is and I love the way you're talking to the family and making a relationship work, because this is a difficult waters that you're in.
Waters. Well, let me just add something here to this, because you're talking about now a teenager, and one of the things you have to be careful about is that we as pediatricians often don't take into account erectile dysfunction coming from SSRIs. So typically, adolescent sex drive is high enough that erectile dysfunction isn't a problem even when you're on SSRIs. But when he says he feels sluggish, that he may be sluggish sexually too in a way that bothers him. So you want to be, you've got a great opportunity to make sure you have that conversation with him. But there are kids who basically just don't feel as driven when they're on SSRIs. Now, that's good for a lot of kids, right? That's part of what you're aiming for. But if you're a driven swimmer, to not feel driven is actually a problem for them. So it may be that if his swim season isn't year-round, he may want to adjust when you address his anxiety to when he has to be at his peak performance. I mean, all of that is something to keep in mind. Now, don't forget that you're not supposed to suddenly stop SSRIs, and you can feel kind of sick, a little like flu-like symptoms. If you stop them suddenly, at least things like sertraline, which is Zoloft. Prozac has its own long half-life that protects you from having a big drop-off, so it's not quite as serious there. Well, I think we're about out of time here, so this is our new format to talk about whatever you guys want to talk about. I must say I enjoyed this conversation and hope it was helpful to everybody. bhoward@chattis.com. Don't forget to send me one or two things you'll do differently or think differently about. And we'll continue 12 to 1 on the third Tuesday of the month. So please tell your colleagues, and we do have nursing credit available also.